Hello, let's start about rhythm of the ECG. The AC note generates a regular sinus rhythm that paces the heart. Each pacemaker impulse from the AC note spreads through both atria as an advancing wave of depolarization. AC note or sinus note, sinus rhythm normal 60 to 100 per minute. On ECG, there is a constant distance between similar waves during a normal regular cardiac rhythm because the AC note's automaticity precisely maintains a constant cycle duration between the pacing impulses that it generates. Normal regular rhythm. Sinus arrhythmia. AC note's pacing rate normally varies with respiration. Note, sinus arrhythmia is a normal but extremely minimal increase in heart rate during inspiration and extremely minimal decrease in heart rate during expiration. The slight increase in the heart rate is due to inspiration activated sympathetic stimulation of the SA node. The slight decrease in pacing rate is due to expiration activated parasympathetic inhibition of the SA node. Perhaps you knew that already, since sinus pacing is regulated both division of the autonomic nervous system. Now, atrial conduction system. The atrial conduction system consists of three specialized internodal tracts in the right atrium: the anterior internodal tract, middle internodal tract, posterior internodal tract, and one conduction tract known as Bachmann's bundle that innervates the left atrium. The depolarization stimulus passing down from the atria reaches the AV node. The stimulus slows in the AV node, producing a pause in the ECG. Atrial contraction, AV node depolarization slows down. This is AV valves, POFs, and pause. After passing slowly through the AV node, reversion proceeds rapidly through his bundle branches, and their subdivision through the terminal Purkinje filaments to distribute depolarization to the ventricles. Ventricular depolarization produces a QRS complex on the ECG. QRS complex on the ECG. The Purkinje fibers of the ventricular conduction system rapidly conduct depolarization away from the AV node to the endocardial surface of the ventricles. When the ventricles depolarize, it produces a QRS complex on ECG. Ventricular depolarization begins midway down the interventricular septum. The left bundle branch produces fine terminal filaments. The right bundle branch does not produce terminal filaments in the septum. So, left to right depolarization of the septum occurs immediately before the rest of the ventricular myocardium depolarizes. Depolarization of the Purkinje fibers takes longer than ventricular depolarization. That is, the end of the T wave marks the end of the ventricular depolarization. However, depolarization of the Purkinje fiber terminates a little later. Beyond the end of the T wave, the final phase of Purkinje depolarization may record a small hump, the U wave following EKG. Now, arrhythmia. Arrhythmia have irregular rhythm, escape, premature beats, tachyarrhythmia. Irregular rhythms, three types: wandering pacemaker, multifocal atrial tachycardia, and atrial fibrillation. In some hearts with structural pathology or hypoxia, malfunctioning automaticity foci may suffer from entrance block, whereby any incoming deposition is blocked, protecting them from passive deposition by any other source. Such protection is not healthy. By being insensitive to passive deposition, they cannot be overdrive suppressed, while their own automaticity is still conducted to surrounding tissue. When an automaticity focus has entrance block, it is said to be parasystolic. The focus passes, but cannot be overdrive suppressed. Winding pacemaker. Characteristics of winding pacemaker: irregular rhythm, P prime wave shape varies, atrial rate less than 100, and irregular ventricular rhythm. This is P prime, another P prime, another P prime, and P prime. Everyone has different shape. Atrial rate less than 100, and irregular ventricular rhythm. So, winding pacemaker is an irregularly rhythm produced by the pacemaker activity wandering from the AC node to nearby atrial automaticity foci. This produces cycle length variation as well as variation in the shape of the P prime waves. The overall rate, however, is within the normal range. Then multifocal atrial tachycardia. It is also irregular rhythm. Where P prime wave shape varies, atrial rate exceeds 100, and irregular ventricular rhythm. P prime shape varies, different shape, different P, different shape, different P. Atrial rate exceeds 100 and irregular ventricular rhythm. Multifocal atrial tachycardia is a rhythm of patients with chronic obstructive pulmonary disease. The heart rate is over 100 per minute with P prime waves of various shapes since 3 or more atrial foci are involved. 3 or more atrial foci are involved. Atrial fibrillation. This is also irregular rhythm where continuous chaotic atrial spikes presents and irregular ventricular rhythm present. Atrial fibrillation is caused by the continuous rapid firing of multiple atrial automaticity foci. No single impulse depolarizes the atria completely, only an occasional random atrial depolarization. This is the AV node to be conducted to the ventricles. This produces an irregular ventricular rhythm. Atrial fibrillation is not an arrhythmia of healthy young individuals. It is the result of multiple irritable atrial foci suffering from entrance block, pacing rapidly. These multiple atrial foci are parasystolic, so they are all insensitive to overdrive suppression. Therefore, they are all paced at once, not chaos. The P waves are not identical. The rate does not gradually increase and gradually decrease, so we immediately know that it is not sinus arrhythmia. The rate is less than 100, which rules out multifocal atrial tachycardia. The rhythm is irregular and the P prime waves are of different shapes. This is most likely wandering pacemaker. Now, escape rhythm. Escape rhythm, an automaticity focus escapes overdrive suppression to pace at its inherent rate. 3 types: atrial escape rhythm, junctional escape rhythm, ventricular escape rhythm. Escape beat, an automaticity focus transiently escape overdrive suppression to emit 1 beat. Atrial escape beat junctional escape beat, ventricular escape beat. Escape describes the response of an automaticity focus to a pause in the pacemaking activity. Sinus node pacing interrupted by sinus arrest. Automaticity focus escape to become an active pacemaker. Help. With sinus arrest, the AC node ceases pacing, then absent overdrive suppression by the AC node, and automaticity focus with the fastest inherent pacing rate escapes to become an active pacemaker. And since it has the fastest inherent rate, the overdrive suppress all foci below to become the dominant pacemaker. Sinus rhythm, atrial escape rhythm. With sinus arrest, and here with sinus arrest and atrial focus quickly escape overdrive suppression to become the dominant pacemaker at its inherent rate. This is atrial escape rhythm. Junctional escape rhythm or idiojunctional escape rhythm, the rate 40 to 60 per minute. Absent regular pacing stimuli from above, an automaticity focus in the AV node junction may escape overdrive suppression to become an active pacemaker, producing a junctional escape rhythm. Junctional escape rhythm in its inherent rate range 40 to 60 per minute. The junctional focus escapes the influence of overdrive suppression if there is a sinus arrest, and the atrial foci also fail to function properly, or if there is complete conduction block in the proximal end of the AV node. In either case, the junctional focus is not regularly stimulated by pacing depolarization from above. A junctional automaticity focus may cause retrograde atrial depolarization. Each P' is inverted in leads with an upright QRS. Because each junctional automaticity focus is located within the AV node, each pacing stimulus originating there will conduct to the ventricle as expected, but the paced stimuli may also depolarize the atria from below, that is retrograde, producing inverted P' waves in ECG leads with an upright QRS. Yeah. This is. The illustration shows that atrial depolarization and ventricular depolarization proceed in opposite direction from a pacing junctional focus. Also, most ECG leads produce an upright QRS. Now, ventricular escape rhythm or idioventricular rhythm, rate 20 to 40 per minute. A ventricular escape rhythm occurs when a ventricle automaticity focus is not regularly stimulated by paced depolarization from above, so it escapes overdrive suppression to emerge as the ventricular pacemaker with an inherent rate in the range of 20 to 40 per minute. So it is also called an idioventricular. What is the ventricular complexes? Ventricular escape rhythm usually results from one of two mechanisms. With complete conduction block high in the ventricular conduction system but below the AV node, the ventricular foci are not stimulated by atrial depolarization from above. See Peirce in illustration. So a ventricular focus escapes to pace the ventricle at its inherent rate. Total failure of the AC node and all automaticity foci above the ventricle is a rare and grave condition called downward displacement of the pacemaker. In extremis, the ventricular focus escapes to become the active ventricular pacemaker in a final futile attempt to sustain life.